Okay.
All right, nice. So just firstly, to Norrie, thank you so much for taking the time out of your schedule to present to us. Just for those of you who don't know him, I know I'm calling him Dad, but he's actually Prof Gibson, and he's the head of orthopedics at Frere. There's my mum in the background. She's an anaesthetist at Frere. Yeah, he's very kindly offered to talk us through some orthopedics.
So your first scenario is a back pain 2 months in a 45-year-old with a history of weight loss. Okay, so that's pretty much the information that we've got. And there's not much to find on examination, okay, except for some minor tenderness around L1, L2. Okay, so I think the first thing I'd want you to have some sort of approach to is the classification of backache. Because if you ask a group of people, what do you think the cause of backache is, they almost invariably talk about mechanical backache. So I think just to say to you that you must think in terms, look at everything from a distance. So basically backache can either be spondylogenic, which means that it arises from the contents of the spinal column. That's the discs, the vertebrae, and the ligaments. And then think in terms of neurogenic, which means it can arise from within the contents of the dural sac. And then think in terms of vasculogenic, okay, which is a bit of a combination of things, but basically vascular, or rather neurogenic. Let me have a look. Vascular can be a referred type from somebody who's got an abdominal aortic aneurysm, or it can be somebody who's got insufficient blood supply to the spinal cord. Okay, and then neurogenic, which is what have I got? Spondylogenic, vasculogenic, then viscerogenic, which is referred from your viscera. So you must understand somebody with a penetrating peptic ulcer, somebody who's got pancreatitis can present with backache. And if you don't think of those things, you're just not going to find them. And then the last one is psychogenic, and it's always last because it's the diagnosis of exclusion. Okay, so those would be the 5 groups of patients that could present to you with backache. So the first thing is classification. The second thing would be that common things occur commonly. So if you look at the spinal column and you think in terms of aging, you as a youngster have a well-hydrated disc. And as you get older, your disc desiccates. Okay, so that basically means that younger people tend to get disc-related problems. Middle-aged people tend to get segmental instability and mechanical backache. And older people tend to get the effects of the body healing itself by throwing out new bone, hypertrophy of ligaments, discs, etc., which causes spinal stenosis. So if you have a younger patient presenting to you, you can think of a disc herniation of one of its varieties. If you have a somewhat in this age bracket, 45-year-old, you're really thinking the commonest thing that's going to present is some form of mechanical backache. Okay, so let's just try and have a few things to look at. Okay, so your question is red flags. Maybe just throw it out there and ask if anybody wants to sort of give some sort of input with regards to a red flag.
I think if there is like weight loss, if there is fever, if there is obvious deformity, if there is history of trauma.
Okay, that's good. So maybe think like this. Okay, so if you're thinking of a fracture, so with regards to a possible fracture, your red flags would be a history of major trauma, because they have associated spinal column injuries that if you don't go looking for them, you need to look for them. And secondly, with minor trauma, you must always be suspicious in the elderly that they may have it. So if you're thinking about possible fractures, then the level of trauma and the age of the patient. Then if you're thinking in terms of tumors and infections, then extremes of age, so less than 20, older than 50, a previous history of cancer, constitutional symptoms, and this is your patient, no fever or chills, but definitely subjective weight loss. So that would constitute a red flag. A history of recurrent bacterial infection, an IV drug user, somebody who we know is immunosuppressed, and also an important one is the patient who presents with pain predominantly at night. Okay, so night pain classically in the back is from either a tumor or infection. So that would be the tumor infection group. And then the neurological deficit group would be a person who's got progressive motor or sensory loss, somebody who's got bowel or bladder dysfunction, somebody who's got bilateral leg pain. Okay, and when you examine the patient, if they've got objective neurological deficit, and that includes perineal sensory deficit, those would be your red flags. So I've grouped them into trauma, into tumor and infection, and into neurological deficit. So those, my understanding, those would be how I would look at red flags. Okay, so basically your patient is middle-aged, 45. He's got a history of weight loss, which is subjective. I don't know how, it's difficult to know how to objectivize that. But if a person had no red flags, then your treatment is going to be supportive with rest, anti-inflammatories, and avoidance of any activities that might aggravate it. If a person's got the red flags, basically, then you're going to be guided by which red flags they've got. So if a person's got something that points you towards the tumor infection group, then I think probably it's reasonable to do some routine bloods. And your bloods would be your inflammatory markers. I would do a PSA. I would want to do some bloods to give me an idea with regards to the patient's nutritional state. So I'd do a serum albumin and I'd do hemoglobin. Despite the fact that the patient's not telling you his HIV status, it so often happens to me that people withhold that information. I would ask to do an HIV or a CD4 count. I would do an ALK-Phos, ALP, because if there is a destructive lesion, then you'd see an increase in your bone turnover. And again, with regards to comorbidities, I think in terms of doing an HbA1c. So those would be the bloods that I would do. Would I do an X-ray? I think if I've got positive red flags, then yes, I would. I would do, like I would always do, I do an AP and lateral of the lumbar spine. You said L1, L2, that's fairly high for what I normally see. But anyway, I'd do an AP lateral of the lumbar spine, and I'd do a PA of the chest. With regards to anything else, I think those probably would be all that I would do, and that's quite comprehensive. I don't think you've got access to do all of those things, but on the basis of your clinical history examination and the investigations that you've done, you must decide whether to refer the patient or not.
If I may interject with a question or two. So the first question I have is, in our context, I would say at least half of the patients, obviously there's a pre-selection bias, but half of the patients we're seeing presenting with back pain are HIV positive. And so we end up doing a hell of a lot of workup for TB spine and or for other infective causes. Usually we're doing a CRP and an alkaline phosphatase and a lumbar spine X-ray. One of the things I was wondering about is just when you're doing the physical examination, obviously we're talking about a patient that doesn't have a very clear history of increased exertion or trauma with someone that sort of just have this new onset pain. How important or how useful will it be to differentiate between someone that has point tenderness as opposed to vague tenderness? I'm a utilitarian at heart, and I feel very bad at the amount of lab expenditure I cause every month. And with the amount of people we are seeing with back pain that I'm doing CRPs and alkaline phosphatases on in the HIV cohort that do have significant pain, not necessarily always weight loss, I do feel somehow, I wish there were ways that I could, in my clinical examination or another way, cut down on doing unnecessary tests.
Okay, I think that's very good. I think you're making some very good points there. I think two things. I think first of all, being people in the district hospital environment, you're not seeing this and doing it all the time. So there's no shortcuts to your history and your examination. And I think whereas I might spend 10 minutes with the patient, you should probably spend half an hour with the patient trying to just go from A to Z with regards to getting everything and ticking all the boxes. And the second point would be, unfortunately, we live in a world of we have to practice defensive medicine. In my time when I worked where you're working now, and in that type of environment, we got away with all sorts of things that you just can't get away with today. So you have to tick those boxes whether you think they're not. And defensive medicine is expensive medicine. So There's no substitute for good clinical examination. I agree with you. I think one needs to spend time with that. But unfortunately, if you miss something today, you could be held to task about it. So the basic, I think doing serum albumin levels, I know there are people that say it's an expensive test and maybe that's not necessary, but doing a ESR in somebody who's HIV positive is not that helpful because the result is so, I don't know how to explain it. So a CRP probably would be better. So I would do inflammatory markers. I'd do a diff count. I would do a CRP. I think it's, if you want to limit it to that and then sort of work forwards depending on the results you get. I don't know if that's helpful to you.
I mean, it does help. One of the things that I was wondering about is the extent of mobility reduction and the extent of point tenderness as opposed to paraspinal tenderness, whether those would have a contributive effect in reassuring me as opposed to forcing me to do more tests.
Okay, so with regards to trauma, I specifically look for midline tenderness. So when I'm examining somebody with a history of trauma and I'm looking at the back, I'm trying to work out whether the trauma is muscular or whether it's actually from the spine itself. So most patients who have trauma to the spine with an injury to the spinal column will have midline tenderness, whereas patients who've got have got a sprain are going to have paraspinal tenderness. But I don't think you can necessarily translate that to somebody who's got an infection, because the symptoms that they present with are very variable. Is it going to refer? If it does refer, does it refer below the knee, above the knee only? So does it refer to the tummy, to the groin? That's very variable, and I don't think you could use where they feel the pain outside of the trauma setting to point you in a direction. How will you use the results of the investigations? Pretty much, if you've got a high PSA, I think you need to go. You need to know where you're going to go. If you've got somebody who's got a lymphocytosis, high platelet count, I think you're thinking in terms of maybe looking further for TB. If there's any change, I mean, the vast majority of patients at 45 are going to have early degenerative changes in the spine. If it's not localized to the level at which the patient's symptomatic, I think that's probably irrelevant. But yeah, I think looking at X-rays, unfortunately, looking at X-rays of the spine, they're fairly straightforward if you look at them every day. If you're looking at them once in a while, you're definitely forgiven for not being confident, and it's why in many casualties around the world now they're doing sagittal reconstruction CT scans for all their trauma neck, because they just haven't got the expertise, and they give the responsibility of making the diagnosis to a radiologist. Again, it's just defensive medicine. So I think what you do further is going to depend on what you find from your clinical, what you find from your investigations.
Cool. I think that's very helpful. So we maybe move on to the next case at this point.
Okay, can I just maybe just say to you then that the vast majority of your patients are going to come up with nothing, and then you need to start thinking in terms of what are you going to do for them, and basically you want to rest and avoidance of activity problems, but you do need to sort of give advice with regards to posture, with regards to core muscle strengthening. So you've got and I know at Madrileni, and I'm sure Zitalele, I'm not quite sure where the other guys are from, but you've got very good paramedical services, your OTs, physios. Just try when you're writing referrals to the physios to ask for specifically what you want. Not write backache, please treat, but just say, patient 2-month history of backache, please do postural correction. Just get into the habit of knowing what you're asking for, rather than giving the responsibility of managing the patient to somebody who hasn't actually seen the patient before. Okay. All right, Dylan, should we do the second case? Okay, I'm not sure that I got all your questions on this one, but you're working at district hospital casualty, patient so it's a PVA. Patients arrive, got severe pain, left lower leg, got a significant wound of the lower leg with the bone protruding. So, okay, so he's got an open fracture. Your questions with regards to this? Is there? Oh, you have got. Okay. Well, I didn't see this slide, so I'm glad that it's done that because the first thing I wanted to tell you is that an open fracture is a distraction, and I mean, so many times I get referred a patient who's got an open fracture, and in fact they just haven't looked further to identify other sources of pathology. So we not infrequently have people with neurological problems, with head injury problems. And just because it's an open fracture, it gets sent to an orthopedic clinic. Okay, so that's the first thing. So remember ATLS and look at your ABC principles. Grading system, I suspect, I mean, the most universally used one is Gustillo and Anderson. Do I have to explain that, or are you happy that you know what the Gustillo-Anderson is?
I think it might be nice to go through it quickly.
Okay, so Gustillo and Anderson, basically what it usually, it should relate to what you classify the patient Gustillo and Anderson definitively in theatre. Now you guys aren't in theatre, but that's where it's supposed to be used. But you're going to see the patient, and what you're trying to do is you're trying to work out the amount of energy absorption. Okay, so Gustillo and Anderson 1 is puncture wound. There's no bone penetration. There's minimal, if any, contusion or contamination. Okay, so it's a low energy open fracture. So it's less than a centimeter. So Gustillo and Anderson type 2 is a wound between 1 and 10 centimeters, but again, minimal soft tissue devitalization. Okay. And a Gustillo Anderson type 3 obviously is a higher grade where there's necrosis of muscle fat, there's contamination with foreign material. The bone could easily be sticking out the skin, and we divide it into an A, B, and a C. An A, which is what I've described. A B is where there's bare bone exposed. In other words, the periosteum has been stripped off the bone and the bare bone is exposed. And a type C would be where there's a vascular injury that requires surgical repair. Okay, so just to add to that classification, all compound femur fractures are regarded as grade 3 because there's a large soft tissue envelope. So for the bone to have penetrated, it must have been quite significant trauma. All segmental fractures, all farmyard injuries, and all high velocity gunshot wounds, they're all automatically grade 3. Okay, so the Gustillo and Anderson classification where you are would guide you with regards to the antibiotic choices that you make. Okay, so if you've got a Gustillo and Anderson grade 1 or 2, then basically first generation cephalosporin, as in cefazolin, would be an appropriate antibiotic to start. And if you've got a grade 3 open fracture, then you should add minor glycoside to it. And you should consider in a farmyard injury also using metronidazole. So those would be your antibiotics. And I think what the statistics show us today is that the most important thing that you can do early is start antibiotics. So the joke side of it would be to say, if you can give the antibiotics before the accident, that's the best time to give it. Okay, so early initiation of antibiotics is most important. So once you've done that, then you want to clean with copious amounts of fluid. You want to put on a sterile dressing, and having put the dressing on, you don't want to open it every 5 minutes to show your colleagues how bad it is. So when you put your sterile dressing on, leave it on. Then you want to splint the fracture, give analgesia, and don't forget tetanus toxoid. Okay, so that, what is the grading system we've done, how do you manage the patient is what I would do. And then obviously referral of the patient. So we used to teach that you need to have done your initial debridement of the fracture within 12 hours of injury. There are several studies that are coming out now that say that if your initial debridement is within 24 hours, there's no negative influence on your infection rates subsequently. So I don't tell my anaesthetists that because then I'll never get into theatre, but the emphasis is on the timing of the initiation of antibiotics and of course early referral, so we can put the patient in the queue to get into theatre. Obviously, when the patient's referred, there will be a formal debridement and stabilization and a plan for soft tissue coverage, but that's not what you're going to be doing in your district hospitals. A question might be, are you going to suture the wound or not? If it hasn't had a debridement, the principle would be that you shouldn't suture the wound. The problem that we have is that our ward spaces are so close together that with changes of dressings in the ward, it just becomes dangerous to open and close the wound. So if we can close the wound without tension, then we would probably close the wound. But the temptation then is you go back for your second look and the wound looks fine, and you just look, you don't take the stitches out. Whereas a second look procedure is actually a formal decision-making as to definitive care. So you don't want to fall into that trap. Okay, so the 5-year-old girl, 2-day history, not walking, groin and right iliac fossa pain, constitutional symptoms, and on examination, pyrexial tachycardia, the legs in a flexed position, and she doesn't want to allow movement because of pain. That's a pretty typical scenario. Okay. So I think the first thing to say is you really do need to have a broad differential diagnosis. Hip septic arthritis is what's obviously staring at us in the face. But just again, just like with your approach to backache with those 5 groups, just have an approach that says the pain can be referred pain, it can be infective, it can be inflammatory infective, and if it's inflammatory infective, it can be acute or chronic. If it's inflammatory, it can be inflammatory non-infective, and that could be seronegative or seropositive. Then it could be a trauma, it could be a tumor, and it could be a perthes. So those basically would be the sorts of things that I would try and have on my list to exclude in every patient that I see. I think if it's infective and it's acute, septic arthritis is one of your diagnoses, but appendicitis, mesenteric adenitis, inguinal adenopathy, and ischiorectal abscesses are things that I've seen each of those before, and they can present because they cause irritation in the hip, so they can present in a similar way. Okay, so that would be my advice to you with regards to think broadly. With regards to the position of the leg, the reason why it's actually held in flexion, abduction, and external rotation. The reason for that is that the capsule of the joint is a spiral, and you can increase the volume of the joint by doing that, putting the leg in that position. So if you put the leg into flexion, abduction, external rotation, you increase the volume of the hip joint, which means that the fluid that's in the joint is not causing as much pressure, and it's tension in the joint that causes pain. Okay, so that's why they lie in that position. From an exam technique point of view, I'm sure you guys are probably better at examining patients than I am, but I make a point of examining from the area of the patient furthest away from where I think the pathology is. So I'll always examine the right leg first if it's the left leg that's involved, and I'll work towards the area to try and exclude as much as I can before I lose control with the patient not being happy with me, and to give them the confidence that I'm not doing anything horrible to them, so that I can. And I find probably 50-75% of the time I can get to the point of pathology, and I've excluded all sorts of things by the time I get to the hip joint, for example. Okay, so exam technique's important. Special investigations, definitely with your bloods, inflammatory markers, blood cultures, X-ray. You're going to do ultrasound. I think more important in a younger child than the 5-year-old, but I'd still do it. I'd still want to do an ultrasound, and I'd probably aim to try and do an ultrasound guided aspiration.
So one of the cool applications of point of care ultrasound is to use hip ultrasound to diagnose hip effusion. Every pediatric care providers know that it's really hard to diagnose children to present to the emergency department with a limp and fever. Hip ultrasound can actually be helpful to identify the presence of a hip effusion for those patients. In conjunction with the rest of the physical exam findings, lab investigations, I believe hip ultrasound can be one of the useful tools to guide management of these patients. So in order to achieve proper imaging of the hip, the patient needs to be lying supine with the leg in slight flexion and abduction, as much as is tolerated by the patients who are often having some hip pain. So proper pain medication should also be offered to the patient. The probe that should be selected to do hip ultrasound is the linear probe for younger and smaller patients, and a curvy linear probe can actually be used for adolescent or heavier patients who need a depth of more than 4 to 5 centimeters. When the patient is positioned supine with the hip in abduction, you look at the inguinal crease, and the ultrasound probe actually has to be perpendicular to that hip crease. This actually follows the femoral neck of the patient. When the ultrasound beam is perpendicular to the inguinal crease and parallel to the femoral neck, you can actually visualize the femoral neck, the femoral head, and the acetabulum in the long axis. In order to see whether the patient has a hip effusion or not, what you need to look at is to look at the femoral neck and the iliopsoas muscle next to it. And what you're looking for is you're looking for a hypoechoic kind of fluid collection in this area. The measurement needs to be done at the level of the femoral neck, and if the fluid collection is more than 5 millimeters on the affected side, or if there's a 2 millimeter difference when you compare to the unaffected side, then it's considered a pathologic hip effusion. The trick is to always compare to the other side in order to see if there's a difference. The hypoechogenicity of this hip can actually be tricky because in cases where there's a purulent hip effusion, the area and the fluid collection can be not 100% black, so you should still take it into consideration. Identifying a hip effusion can be quite helpful for a primary care provider, or also seeing that there's no hip effusion can be reassuring. But unfortunately, it doesn't help us differentiate between two different diagnoses, septic arthritis and transient synovitis, which have very different prognosis for the patient. So I think the use of hip ultrasound to diagnose hip effusion is a useful tool when it's used in addition to other clinical factors and lab investigations.
Okay, gram stain is quite quick to give you a result. I see, Dylan, you've got a blood culture result for staph sensitive. That takes a bit of time, hey? So I don't think you're going to get an MCNS result in the time it takes you in order to make a decision as to what to do. If you've got a clinical, so you've excluded, you've done a log roll, you've excluded ischiorectal abscess, the abdomen, there's no peritonism, so there's no obvious appendicitis. You've excluded a lot of adenopathy causing pain. You've looked at the leg, see they haven't got a septic wound in the toe or the foot. So you've done those things. So now you've diagnosed that it is in the hip. You've done an ultrasound. You have got fluid. You've got a blood culture. Let's just say it's given you a positive gram stain. I think now I would say an ultrasound guided aspiration is helpful, and then I think you need to go to surgery before. If you've got specimens, if you've got your blood culture, if you've got your aspiration, I think you can start your parenteral antibiotics. If you haven't got a specimen, then you have to decide, shouldn't I start antibiotics? And if you've got somebody who's constitutionally unwell, tachycardia, low blood pressure, respiratory symptoms, I think you have to start antibiotics, even though the specimen you get, the yield rate on what you send to the laboratory later is compromised. But if the patient's not systemically unwell, I would try and get the patient to theatre ASAP and get the specimens before starting the antibiotics. So the initiation of antibiotics is going to compromise your yield for the specimens that you send. I did say last time, with regards to your blood culture, when a patient presents with a septic arthritis, it's an emergency. So I doubt that you're going to get a sensitivity in time in order to make your decision making. So you may well have a gram stain on your blood culture, but I doubt that you'd have a culture of a specific organism or sensitivity yet. Okay. So that's the first thing. The second thing is I wanted to talk to you about the Cochra Criteria. Are you aware and comfortable with the Cochra Criteria?
Never heard of them.
Okay, so Cochra, it's a guy I think with TB as well, Kocher. So he devised 4 criteria with regards to the likelihood of it being a septic arthritis. and it was described to distinguish in the hip a transient synovitis from a septic arthritis. So, the last time we spoke about the differential diagnosis, and we mentioned that there's a big list of things that could cause somebody to struggle with walking and have a painful limp or refusal to weight bear. But if you had to differentiate between a transient synovitis and a septic arthritis, then these Cochra criteria are quite helpful. And they are 4 things. The first is a white cell count of greater than 12. The second is inability to weight bear. The third is a temperature in excess of 38.5 degrees Celsius. And the fourth one is an ESR of more than 40. 40. So if you have only one of those criteria, then the likelihood of it being septic arthritis is 3%. If you have 2 of those criteria, the likelihood of it being septic arthritis is 40%. If you have 3 of those criteria, it's 93%. And if you have 4, it's 99%. So if you've got a white cell count, the refusal to weight bear, a temperature in excess of 38.5 and an ESR of 40 or more, then if you've got 3 of those, which you're quite likely to have, then it narrows down your differential. Rather, it tends to exclude it being a transient synovitis. So it would mean that you almost definitely got a septic arthritis. Okay, so Cochra criteria, if you've got 3 or 4 out of the 4, then it's a high likelihood of it being a septic arthritis. Okay, then there was another association between CRP and refusal to weight bear. If your CRP is, I don't even know what the figure is, but if it was significant and refusal to weight bear, it's a 75%. So obviously people have put together these criteria to try and help you confirm the diagnosis of septic arthritis. So let's talk about organisms then. And it really has to do with age groups. So if you've got a septic arthritis and you're a neonate, then your most common organism is a group B streptococcus. Okay, if the child's more than 2, then it's going to be your commonest organism is a Staph aureus. If you've got an adolescent, then assuming that adolescent is sexually active, then Gonococcus is your most common organism. And then the other organisms that they might have, I mean, there's a variety of them. So basically, if you've got a neonate, group B strep, if you've got a child that's older than 2, you're thinking about a Staph aureus. Adolescent, gonococ. So your most likely organism in your 6-year-old is a Staph aureus. Okay, so I mean, you've told me your culture on your blood culture already. So that will be your differential organisms.
It's interesting. I mean, this case that I'm projecting now, this is a real case of a child that came in to euthanasia casualty with a painful right hip and not able to weight bear, and then we did a blood culture, and the culture came back as a cloxacillin sensitive Staph aureus.
Okay, so you've got 3 of Cochra's criteria there. So you've got an ESR, you've got a temperature 38.5, and you've got the blood, and you've got refusal to weight bear.
Yeah.
Okay,
yeah, I think
so
the temperature was 39 or so.
Yeah. So I mean, you could almost definitely diagnose it just based on that.
In terms of empiric products, so I don't know about Frere, but we've really struggled with access to IV cloxacillin. I haven't seen a vial of IV cloxacillin in years.
It's not available nationally, so that's not an Eastern Cape Department of Health thing. It's basically they just haven't produced it. No, and I'm sure that's something that is going to come back, but it's not available at the moment. So we would use a first generation cephalosporins. We'd use cefazolin.
Yeah.
Okay.
And then
clindamycin if you've got an allergy problem. So first generation cephalosporin because it's quite specific for gram-positive cocci. And then if the patient wasn't responding, adequately, then, and we knew we had an organism and a sensitivity, then we'd probably add fusidic acid as a second-line drug.
And then just quickly, what are your thoughts on oral antibiotics in orthopedic infections? I know there's a little bit of like controversy around that.
So obviously a septic arthritis of the hip is an emergency because the toxins released from the response to the infection destroy cartilage. So one, it's an emergency. Two, that means surgery, it means admission. And if your patient's admitted, then we would put them all onto intravenous parenteral antibiotics. And we would convert from IV to oral when the temperature's been down for 24, 48 hours. Okay, some people would do it based on the response of the CRP, but those would be things that you could.
All right, shall we move on to the last case then?
21-year-old, 1 week history, progressive pain and swelling of his right knee, previously, well, no known comorbidities, no history of trauma. And then on exam, you've got a warm, tender knee with a positive patella tap. That's obviously a test you do for an effusion. He's got reduced range of movement in flexion, and otherwise he's systemically, or he appears well. Okay, so do you want to just? I think your next one was asking for a differential. Do you want to go through that with me, Dylan, and tell me what you think of it as a differential?
Yeah, sure. So things, but my top three would be septic arthritis, reactive arthritis, and gout. Good.
Okay, and I think 95% of the time you're going to be correct in what you say. So as from an educationalist point of view, it's always good to think in terms of congenital and acquired, and then go through your different groupings. Can you hear me?
Yeah.
Okay, so with regards to congenital or genetic things, just remember it's a male, it's 21. There's a possibility that it could be a hemophilia. Okay, so just, it's highly unlikely that somebody's going to present with a swollen joint with hemophilia at 21. It's going to have happened much younger, but maybe it has and you just don't know. So somebody who's a male who's got a swollen joint, I'd certainly have hemophilia somewhere on my list. And because my differential starts with congenital and acquired, it would probably be the first thing I say, not because it's most likely, but just to get it out of the way sequentially. Okay. So then acquired. So you've got no history of trauma or mechanical issues, but you mustn't exclude that based on history. A whole bunch of youngsters get drunk, they get injured, they wake up and they can't remember what happened. Then they've got a swollen knee and they come for help. So I think the trauma mechanical things have to be on your list of differentials. So, and with that, you should include a foreign body. You should include a loose body. So somebody's has got osteochondritis dissecans, and that fragment has now become loose. It can act as a loose body in the knee and give a locked knee. I must think in terms of discoid meniscus, think in terms of a plica, or just somebody who's got overuse. So those would be my mechanical trauma list of things that I would have there. Then if you look at inflammatory, then you can think of inflammatory infective or inflammatory non-infective, and your infective can be acute or chronic. And your acute infections can either be arthritis, cellulitis, or bursitis, which is where it's important to have picked up that, in fact, there's a positive patella tap. So it's not uncommon to get presented a patient, usually a child, but it's not uncommon to get presented with a patient from casualty as a septic arthritis, and they've got a pre-patellar bursitis. Okay, so if you've demonstrated that the fluid's inside the joint, then you've excluded that. Okay, your chronic infections we won't go into because it's a 1 week history, but your non-infective, think of seropositives, seronegatives. So unusual, but not impossible to be a rheumatoid presenting with the first swollen joint. Seronegative, You've mentioned gout, shooter gout. Think in terms of Angst-Bond and SLE. Okay, so those would be things that you could think about. And then sometimes you get a sympathetic effusion. So you'll have somebody who's got an osteomyelitis of the femur, and they have a swelling of the knee. It's a sympathetic effusion. So if you aspirate that, that's sterile. So I think in terms of that, just because there's an effusion, don't assume that the pathology is in the knee joint. It could be in the bone on either side. And a tumor, I think we're sort of a little bit like rocking horse manure now, but synovial sarcomas, chondromatosis, synovial chondromatosis, those are all things that you could get. So you're quite right with regards to what you said as your top three, but if you think a little bit more laterally and have an organized approach to everything with differentials, then you don't forget or leave out the things that are less likely. I don't know if you find that helpful.
Yeah, definitely. And then just quickly, I know it's not really relevant for this case, but in terms of chronic infections, TB of the knee, is that something that you've seen much of?
See it a lot, yeah. So definitely see TB. We in our immune compromised patients, we see fungal infections. So hydatid. I can't recall seeing hydatid involving a knee, but hydatid involving a bone, yeah, I've seen that. And I suppose that those things are obviously be dependent a little bit on your demographics.
Yeah, so and the differentiating feature there would be the timeline, right?
Yes, chronic, we normally think in terms of chronic is more than 3 weeks. But I think there's, this whole thing of definition of bone and joint infection is, and what's chronic, what's subacute, what's acute. I think that's a little bit still being debated, but I think you've got a history of progressive swelling in a 21-year-old 1 week, so the most likely diagnosis is going to be gonococcal. Okay, so with your gonococcal, I mean, when you examine, you said the rest of the examination was normal, but you should look for a rash and ask about a rash, because 60% of your gonococcal patients will have an associated rash. With one sexually transmitted disease, there are possibly others also. So I think in terms of penile discharge, arthritis, look for eye signs. I'm thinking in terms particularly of chlamydia, and that would affect your treatment going forwards also. Okay, so when you've got a history of a swollen knee young adults don't generally get septic arthritis, so that's why gonococcal is going to be top of your list with the other things we've mentioned. So just try and help yourself, because you'll find in a district hospital and even at Frere, it's very difficult to actually get a gram positive for. You've got to get your specimen to the lab immediately. You've got to have access to chocolate agar. So it's not that easy to culture or grow a gonococ. So most often we treat it empirically. Okay, so we've done differential diagnosis. So you've got this patient, so we're going to do an X-ray, AP and lateral, and I would do it routinely on every patient because you want to, if there's something there to see, whether it be a fracture, a loose body, you'd be able, effusion, you should be able to see the lines, fat pads, etc., to make that diagnosis. Then, are you going to aspirate the knee? I think certainly where you are, you've got access to laboratory. So doing an aspirate, yes. What are you going to ask for on your aspirate? I want a white cell count. I want a percentage neutrophils. I want to look for crystals. I want to measure the glucose. Okay, I think that's what I've got. That I think that I would need to do. Some people ask for procalcitonin. I'm not sure you're going to have access to that. We haven't. And then, of course, doing a gram stain and a culture.
And then you'd add like a gene expert if there was a chronic component.
Yeah, I think Gene Expert for TB would be great if you were suspicious that it was a possibility. I wouldn't routinely do that.
Yeah. And then just quickly, for those that maybe haven't done it a lot, just talk us through your recommended technique for doing a joint aspirate.
Okay, so if there's an obvious effusion, basically putting a needle into the suprapatellar pouch is the easiest place to get into the knee, where you know you're not doing damage to anything. So either medial or lateral. So basically sterile technique, and effectively basically just superolateral to the patella, and you just need to slide the needle. Don't put too small a needle in, because if it's pus, you might not be able to aspirate it. So I would say a 16 gauge. I try and get a 16 gauge needle to put in. I don't think there's anything too complicated about doing it, but aseptic technique, sterile containers. What have you got access to at Madwaleni? Can you check for crystals?
Yeah, we can. It's not done on site, but they send the sample off to the lab in Untitled.
Yeah. And can they do a white cell count on your or a neutrophil percentage? Can they do that? Do you know?
I've never seen a neutrophil percentage, but yeah. White cell count, I mean, it's the same as CSF, I guess, so they are able to do that as they would for an LP. Yeah.
Okay. About all right. So you've now aspirated the knee and you've looked at your effusion, right?
Yeah.
Okay. So the fluid that you get, you're going to look at the one table that photograph I sent you. You're going to look for those 6 or 7 things. You're going to look for is it clear? What the color is, then the white cells, percentage of neutrophils, then your culture, whether there's crystals or not. So those are the things that you would look for. And the table compares a normal, non-inflammatory and inflammatory and inflammatory septic. Okay, so that sort of helps you to get to where you want to get to.
Yeah.
Okay, so we've got this painful swollen knee, 1 week history, getting worse, otherwise well. You've done an aspiration, it's cloudy and yellow. You're sent off your specimen for MCNS, and you've made a clinical diagnosis that the patient's got gonococcal arthritis. Okay, so the question is now what to do. Okay, so which antibiotics would you think are most appropriate?
So ceftriaxone, I think, would be the drug I would choose. I'm just not sure about route and duration.
Well, ceftriaxone is a 3rd generation cephalosporin, and as far as I'm aware, it's only parenteral, so you'd have to give it IV. Okay, so there's a lot of resistance around the world now to gonococcus. So the fluoroquinolones were used and are probably abused by lots of people everywhere. So Cipro is a drug that I would like to use because I can give it orally. But I think probably the best drug to use would be a 3rd generation cephalosporin. Okay, but the fluoroquinolones, cephalosporins, there's resistance to a lot of them, certainly in America now. Then the next question would be, so we're going to put, so we've done an aspirate, we've sent it all away, we've made a diagnosis, we've now got our specimen, so we can start antibiotics. We've done that. Now the question is, what do? Are you going to do an arthrotomy? Are you going to do an arthroscopic washout? Are you going to do serial aspirations? So how do you see that? Now, I think a reactive for arthritis, you want probably, I mean, it's not an infection, so you're looking at letting it settle down. If you've got a gonococcal infection, so you've got organisms there, and there's obviously lots of polys, and the polys produce toxins. Toxins are toxic to cartilage, so you want to try and get rid of the effusion if you can. So certainly the first option would be to do an arthrotomy and arthroscopic washout. If you haven't got access to that or you can't do that, then it is acceptable to do serial aspirations. So you've done the aspirate to get your specimen, and you can repeat aspirate the knee in order to get rid of the effusion. So you could do it 2, 3, or 4 times, just to try and ensure that the knee hasn't got an effusion anymore.
Can I just ask a basic question, just zooming out for a little bit? So it seems that this is probably like revealing a bit of a mistake in my reasoning, but I've always assumed that a gonococcal arthritis is a reactive arthritis. Is there a difference between a reactive arthritis to an STI versus like a gonococcal arthritis where there's gonococcus in the joint?
Yes, there is. So I mean reactive arthritis, I'm thinking in terms of Reiter's disease, something where the condition that the patient's got isn't because of the organism or the bugs, but a reaction to something. Whereas a gonococcal arthritis is the organisms causing the infection in the knee. So Dylan, I also know that reactive arthritis and gonorrhea the gonococ can present in a reactive way, but if you've got gonococ in the knee, you must treat it as a septic arthritis. I don't think just treating it with anti-inflammatories would be appropriate. So I think what you're getting at is asking me whether if somebody's got gonococcal arthritis, whether you should just aspirate it for the diagnosis and treat with antibiotics or wash it out. Certainly the teaching is that it should be washed out. So, I mean, they're gram-negative intracellular, extracellular diplococci. It's difficult. So the yield, when you send your specimen and ask for gonococ, is low.
Yeah, so then how are you going to know which one you're dealing with? Whether you're dealing with a reactive arthritis versus an actual gonococcal arthritis?
So the answer is I don't think you'll always know.
Okay.
Okay. So that's why I'm saying I would treat it with a washout or with serial aspirations in a district hospital situation.
What about the color of the aspirate? So in a actual septic arthritis, you'd expect to find like turbid fluid. You'd expect to find pus. Whereas in a reactive arthritis or a gouty arthritis, you'd expect like just a serous exudate. Because in our teaching in family medicine, we are taught when we're doing a joint aspirate to have depomedrol drawn up and ready. And if the aspirate is clear, to then follow the diagnostic aspirate with an injection of depomedrol into the knee, and then to withhold the depomedrol if the aspirate is at all turbid.
Okay, so if you've got, I mean, just remember that Staph aureus is a pus-forming organism, and the different organisms result in different. So if you've got a streptococcal infection, the pus will look a little different than it would if you've got a staphylococcal infection. I'm not sure that the purulence of the fluid would necessarily exclude it from being. If you look at that table that I sent you, there's the four groups: the normal person, the non-inflammatory, the inflammatory, and the septic. And certainly the inflammatory and the septic look similar on that table, cloudy and yellow. But it's the cell count that's sort of that's different. So if you've got cloudy yellow fluid but not frank pus, I don't think you could say from that it's a reactive arthritis, not a septic arthritis.
But if you got quite clear fluid that wasn't cloudy at all,
if you've got clear fluid, then it's highly unlikely to be a septic arthritis.
Okay, cool.
So I'd go along with the fact that if the fluid's clear, but I mean if you've got discolored fluid, but it's not pussy, I'm not sure that you could not sure on that basis alone you could say that it's a reactive arthritis. Yeah. There's multiple criteria one's using, and if you just go on the color of the fluid you get out, I think you're committing yourself to using steroids on potentially an infected knee. I'm not sure that I would. I mean, I've always been anti-injecting steroids into joints, so I certainly wouldn't liberally go and put steroids in.
Okay. So in summary, basically, in the majority of instances, you would most likely, unless you're dealing with a very clearly serous looking fluid, you'd most likely start most patients on antibiotics pending the results of further investigations?
Yeah, I think so, because it depends on what you've got access to in your laboratory. So, I mean, if you can do a white cell count on your aspirate, and you've got more than 50,000 cells per mil, then you can be fairly confident that you've got an infection.
Okay, cool, nice. And then I'm interested to hear what your thoughts are on giving steroids into joints. Like, why do you say that you're generally against that?
Well, because if you're giving steroids and it is infected, then you're giving a potent anti-inflammatory and you're damping the immune response. So, I mean, the patient might feel better, but the infection is going to be enhanced. If you liberally inject steroids, so I mean, I used to inject quite a lot of steroids into joints in my clinic. And you only need one patient to get a septic arthritis from your poor aseptic technique, or the fact that the previous patient had something, etc., to make you wonder whether you haven't created a problem or not. So, if you're going to inject a steroid, then be sure that it's not a septic joint, and be sure that your aseptic technique and the environment in which you're doing the injection is as safe as possible. Okay, so I haven't injected knees, hips, elbows with steroids for a while, and to do it liberally, I'm not so sure that it's such a good idea. So I mean, I know that GPs use steroids quite a lot. I use steroids very little because I'm scared of them.
I mean, yeah, like I said, what we're taught to do in family medicine is to have the depomedrol literally drawn up, and then if the aspirate is clear, to straight away inject it into the knee. That's, yeah.
But just be sure then that when you do your aspirate, you're doing it in a sterile environment with gloves, mask, gown. Be as sterile as you can.
Yeah, cool. I think that's a bit of a good reminder to have.
Yeah. Okay. Yeah. So, all right. So that's okay. So the issue that you brought up with regards to I mean, I haven't read up on reactive arthritis versus, but if you get gonococcal arthritis, certainly the teaching is washout. The teaching is antibiotics, and antibiotic of choice is ceftriaxone, which is parenteral, which means patient submitted. Okay.
Cool. Awesome. Any closing comments? I'm just going to check. I don't think there's any more slides. Yeah. So let's just stop sharing there. There we go. Yeah. Cool. So maybe just to close off, then we've done 4 cases. We've done the back pain case. We've done the open fracture case. And then we've done septic arthritis in a kid and just a swollen knee in a young adult.